so much for joining us for another AWE Week 2025. And it's a true honor today to introduce to you Dr. Huang, who is, which is amazing, professor of medicine and professor of surgery. One day we're going to ask you how did that happen, and at Stanford University. And it's very telling that he is a director of gastrointestinal endoscopic surgery. And we're going to ask him to talk today to us about what is we can expect for the next decade in the field of endoscopic tissue resection. Thank you so much. And before we continue, I have to introduce my partners in crime, as always, Dr. Krinsky and Dr. Nguyen, who are really key to our success here.
Partners
And
in
we can,
crime.
yeah, that's how we accomplish it. Well, shall we start? What should we know for the next decade about tissue resection? And I'm gonna mute myself and turn off my video, and then we'll restart with questions after.
All right. Well, thank you very much, Sonia, for that very nice introduction. And thank you to Phoenix and Mary for your kind invitation to participate in this. Uh, we can talk in our discussion section about some of the questions that you had, Sonia, but we'll go ahead. The topic I've been asked to talk on is endoscopic resection, pushing the boundaries, and it really is with the future of endoscopy. I really do see that this is here to stay. We're going to continue to innovate, and this is going to be a very important part of endoscopy, of our practice. And it's both pushing the boundaries and the merging of boundaries. You ask why or how I got title of professor of surgery. It's by courtesy, but it's an official title at Stanford. And it really was because I work as a surgeon as well, that what we do here in endoscopy is endoscopic surgery. We cut, we take things out. In fact, it's harder, arguably harder than laparoscopic surgery or some of the other open surgeries because of the tools that we have. And so we'll kind of go into this. These are my disclosures. In this presentation, we'll give just a quick review of what enabling technologies we currently have. And then we'll talk about, the boundaries. So the boundaries really are how wide can we go? How big of a resection can we go? And there's really essentially no limit to the size. It takes time, but the real limitation has to do with the fact that we work in luminal structures. And so as we go wider, we become more circumferential in our lesions. And the real question is, how do we avoid strictures? The actual performance of circumferential resections technically is not that difficult. It takes time, but the real challenge is how to avoid the strictures. So we'll talk about that. And then it's about going deeper. We started with biopsies, right? Then we went to EMR, and then ESD, and then now we're going full thickness, and we have a variety of ways of going full thickness. So we'll have, we have the full thickness resection device, which I think a lot of people have already seen and we've talked about in previous conferences. I'll really focus on this submucosal tunneling endoscopic resection, or STIR, and then this endoscopic full thickness resection, which sometimes we call freehand endoscopic full thickness resection. So again, just to review the methods for endoscopic resection, it started with EMR, has evolved into ESD to take out things en bloc. And the whole reason for this is that we want oncologic resections. We want en bloc R0 resection so that there's potential for curative for cure. And EMR, unless it's a small lesion that's less than 2 centimeters and really 1.5 centimeters in order to get really clean margins, doesn't achieve that. And most lesions that we are concerned about, malignancy, are usually over 2 centimeters in diameter. And so ESD allows us for an oncologic resection. And I think that's where we really need to move towards. If it happens to be something smaller, like a carcinoid that still has malignant potential, we can do full thickness resections. In general, I'd say it's safe to do for something less than 1 centimeter. In the colon, sometimes we can get away with things that are a little bit bigger because you can bring in more tissue. In the stomach, it's often harder because the muscle wall prevents us from really retracting much into that full thickness resection device. So it really depends on the location. But, I would say safely anything less than 1 centimeter to really get clean margins, because we want clean, interpretable margins for the pathologist. And then there's submucosal tunneling endoscopic resection and endoscopic full thickness resection, which I'll go into more detail about. So these are the enabling technologies. I mean, it really starts with our endosurgical generator, which kind of drives or allows us to use these endosurgical knives. In the past decade, there's been a growth of various types of knives. And so we have things like the IT knife, the triangle tip knife, hook knife. We have the I-type knives. We have scissor type knives. And then we have more and more retraction devices and methods. And I think traction is critical for doing surgical procedures. I know that some of our surgical colleagues, when they first saw ESD, they thought we were crazy because there was almost no method of traction. But now we are developing more traction methods, and I think the data and experience is becoming clear that traction is necessary to perform good resection procedures. And then another enabling technology that really has allowed us to push the boundaries are the closure devices. We have clips, and we really have closure clips that are designed for closure, such as the Mantis and the dual action clip. We have through the scope suturing devices, so that would be like the X-Tac, and then the over-the-scope suturing devices that really allow us to do full thickness closures and really push the boundaries. And then I'll briefly touch on some robotic-sized devices that hopefully we'll be seeing soon. So first, let's talk about resecting larger lesions, and it's really circumferential lesions. So soon as we get over 75% of the circumference in most luminal structures, especially the esophagus and the colon, we risk stricture formation. And the question is, why do these strictures form? And there's growing data that says that strictures form largely because of muscle injury that occurs during the resection. And that potentially could be related to the type of energy used for dissection. For example, if a lot of coagulation is used, the coagulation spreads. It's more diffuse than cut energy because it coagulates while you're dissecting. But this can also cause thermal injury to muscle, especially something like spray coagulation. So that usually results in deeper thermal injury. And the question is, should we be using a cut current for dissection when doing these semi-circumferential or near circumferential lesions? It also is related to how much fibrosis is there in the lesion. With more fibrosis, there's more thermal injury to the muscle. Also, there's usually more vessels, and so you're having to coagulate more. And coagulation of blood vessels can lead to deep thermal injury from the use of soft coagulation. I always feel that soft is a real misnomer when it comes to coagulation. Soft is actually the deepest form of coagulation. And so when we're using soft coag to coagulate vessels, inevitably some of this coagulation energy goes into the muscle and causes some superficial muscle injury. It might not cause a perforation, but it certainly causes muscle injury that can lead to future fibrosis and stricturing. So this is an example, or this is a recent publication this year that was published looking at muscle injury and refractory strictures. And basically, they looked at the grades of muscle injury. So there is a a grading of a classification of muscle injury after esophageal ESD, with grade 0 being no obvious muscle injury. Grade 1, there's some circular muscle with mild fracture comprising less than 50% circumferential defect. And so this is examples of really kind of grade 1 injury. So they're just really focal, but you can see the muscle fibers. Grade 2 is subcircular muscle with mild fracture comprising greater than 50% of the circumference. So here's some grade 2. You can see actually fracturing of the muscle. There's thermal injury to this muscle. And here you can see that there's thermal injury. And usually this is because there was fibrosis here in kind of creating the dissection. It goes nearly circumferential. Grade 3 has severe fracture with less than 50% circumferential defect. So here you can see splaying of the muscle. So, and then almost exposure of the longitudinal muscle fibers. And then greater 4 is greater damage throughout the entire layer, such that there's really clear visibility of the longitudinal muscle fibers, and consists of greater than 50% of the circumferential defect. So if you look at these grades, if there's really absent or minimal injury, grade 0 to 2, compared to grades 3 and 4, there's a much higher risk of a 16-fold higher risk of refractory esophageal strictures with this. And so this does show that muscle injury does appear to correlate with this. Basically, any muscle injury is going to increase the risk of stricture formation. So we need to figure out a way to minimize this. There have been studies that looked at using steroids, both locally injected steroids as well as systemic steroids. I think really the key thing is if you can get a really clean resection without any muscle injury, I think you're less likely to have a refractory stricture. But we certainly have to look at these techniques a little bit more to figure out other factors that might contribute to this. So moving on to EFTR or STIR. So EFTR and STIR, they're both ways to resect subepithelial lesions, basically. STIR is basically how I think about this is STIR is it allows for an easier closure, and so if you can tunnel to it, it's a useful technique. So basically, you want to use it in areas where tunneling to the lesion is relatively simple, and this is really in the esophagus or the cardia. Cardia is a good place for STIR because full thickness resection is challenging in the cardia and the GE junction. So I like to STIR in those locations. Whereas I prefer to do a freehand endoscopic full thickness resection in locations primarily in the gastric body. Although, if it's less than 2 centimeters in the gastric body, I will consider doing a STIR as well. And I think one of the videos I show is a STIR in the gastric, in the stomach. But lesions less than 2 centimeters, I feel STIR is easier and more appropriate. If they're larger, then the amount of time needed to dissect around the lesion, to expose the lesion in a tunnel, is less efficient. It often has a broader base. And so the resection is, just a little bit more challenging. And so when it's larger, when it's a larger lesion up to 3 centimeters, my preference, especially if it's in the stomach, my preference is just to do a freehand ESD type full thickness resection. So here is a video of a STIR case. So this is, again, in anterior wall, gastric body, towards the lesser curvature, towards the antrum. And so in this one, I felt that it was small enough that I would go ahead and do a STIR to this. And so it's like a G-POM. You do an incision, you do an injection incision about 3 to 5 centimeters proximal to the lesion. And then you tunnel in to the lesion. The benefit of this is that, the dissection is pretty easy. You can really expose the tumor nicely. There's almost always a feeding vessel, or there's a lot of vessels, so you have to be prepared for hemostasis. And so we're using coagulation graspers um, to coagulate vessels that are feeding the tumor. We expose the tumor, and so you can start to see the tumor right here. Um, this has a pretty broad involvement of the muscle layer, but we try and dissect it really carefully. And ideally, there's limited. Ideally, it's just continuous with a circular muscle layer and doesn't really penetrate into the deep muscle layer. But this one did go into the longitudinal muscle layer. You saw that I got a clip on this. When you start dissecting, you want to retract this for a couple reasons. Once you completely free it, you don't want the lesion to fall into the peritoneum. And so I tether it to something so I can pull it out so it doesn't fall in. And then you saw in there briefly the peritoneal fat. This is the lesion that was removed. Again, demonstrating a nice clean capsule. This is the area where it was continuous with the muscle layer. And so this is a nice small lesion. It's about 1.5 centimeters, relatively easy to take out. When you do, one thing that I didn't mention, when you do go full thickness, you need to have, I usually use a 14 gauge angiocath to decompress the abdomen, because air will start filling up and inevitably you're going to need to decompress. So be prepared to put in a needle for decompression when doing either a STIR or an EFTR. So here's an example of a EFTR. So this is a larger lesion, almost the exact same location as the other one. So when I do an EFTR, I mark around mainly because as soon as you inject it, kind of makes it difficult to know where the borders are a little bit. And I just do connect the dot things. The markings are basically to tell me where to cut on the mucosal surface. I don't need to have a margin. So I show this video just to remind everybody that it gets bloody. These things have a lot of vessels feeding it. Probably one of the biggest challenges in doing a full thickness resection is managing the bleeding, because it can get quite bloody. And it's even scarier once you've created the full thickness, once you've gone through the muscle layer and there's bleeding like there is now. Now the patient is bleeding into the peritoneum. And so the challenge is to really control bleeding. Here I'm in the peritoneum. Here's the angiocath. There's the gallbladder right there. There's some blood in here, so I got to make sure that I irrigate that all out. I was able to fully resect it. I'm capturing it with the broth net, and it comes through. I had a little bit of difficulty pulling it through the G junction, so then that was about a 3 centimeter tumor. So I don't like going over 3 centimeters because it's not that you can't resect it, it's hard to get out. And so just think about, the one thing I want to stress when you do this is think as many steps, try and think about the end before you even get started, and ask yourself, okay, if I get this out, am I going to be able to withdraw it? What tools am I going to need? Whenever I do these types of procedures, I always give my staff a full set of equipment that we have to have in the room before we even get started. But then again, because of suturing, we're able to totally close this up. No more tumor, and this is the lesion that was removed, and it basically is a golf ball. It's a little over 2.5 centimeters, very vascular, but we were able to successfully remove this, and the patient did very well. So I do want to show one other thing, a couple things that are on the horizon. So this is a new robotic retraction device that is being made by Endo Robotics out of Korea. So I've been fortunate enough to work with them and do a lot of their preclinical evaluation. So this device isn't on the market yet, but you can see how it rotates. It can extend. The articulating arm could lift up and help with exposure. And so I think, this isn't the robotic type of thing that, you think about the master slave. This is kind of what we call roboticized devices. And it just makes ESD and other types of retraction a little bit easier. This potentially can help with full thickness resections. If we had a tumor. So that last case, it would have been nice to have something like this to help with exposure and um, you know show the underside of these lesions. So this is something that's coming down the pipeline. Another thing that's coming down the pipeline is another suturing device. This is also by Endorobotics, and this thing is a kind of a neat device. It's like the traditional laparoscopic suturing system where you transfer the needle back and forth. This uses barbed sutures, and so you actually don't have to cinch or tie any knots. And surgeons use this type of barbed suture quite frequently, and it allows us to not have to cinch. And this is this is my very first time that I ever used this device, and it's intuitive. You can rotate the you can see how this is rotating, so you can kind of position it so that it's easier to exchange. It's easy to pass back and forth. Uh, uh, and then when you can see that, we're able to close this, you just kind of pull on this to get the barbs so that it causes approximation of the tissue. And it's just very easy to use because you don't have to worry about, kind of twisting your body. The head kind of rolls. It's called rolling stitch, and so you can kind of move it to different places. And once you kind of pulled the barbed sutures, you just finish it with the cut. The one downside is that you do have to retract. You currently have to remove this device in order to put on a new needle. So what are the remaining challenges? Again, when we want to do a wider or circumferential resection, we need to reduce the risk of strictures. So one, what we definitely need to be doing now is inject steroids into the submucosal, not into the muscle. Don't be puncturing into the muscle. Consider using a cut current for dissection to minimize thermal injury to the muscle. And then we just need more effective therapies to prevent refractory strictures, be it stenting or other drug-eluting stents, some other more effective drugs to prevent stricture formation. And then going deeper, we have devices that are designed now for third space endoscopy and endoscopic surgery. We need help with maintaining visualization during full thickness resection procedures. Probably need larger coagulation graspers with physician-controlled rotation, something that I've been kind of preaching about for a quite long time, because gastric arteries are even larger once you get into the muscle and serosa. And then potentially robotic or roboticized devices for resection and suturing. And then further, what's beyond further expansion of third space endoscopy and endoscopic surgery, potentially being able to perform endoscopic lymph node dissection after resection of T1B lesions. And then we definitely need improved methods for localizing active bleeding during full thickness procedures. That's probably the scariest part of doing these full thickness procedures is when bleeding happens and you just can't see. It would be nice to have some, method, like at least surgeons have graspers that they can just kind of large graspers and they can hold on to. We need something probably besides sprays and gels and stuff like that, because we're going into the peritoneum, but something that can really help us localize and visualize active bleeding that's more significant than what we're used to. So that is my presentation. I again appreciate the invitation, and I am open to questions and discussion.
Whatever you call easy is not going to be easy for mere humans. So to start with, you gave a great lecture at the DDW this year on the electrical surgical devices. And you always taught us that part of the equation is technique and the device.
Mhm.
So, what do you, looking towards the future, what do you see current changes in the electrosurgical unit sort of application and techniques, and how do we change what we do to reflect that?
Yeah, I think the most important thing is if you're going to go into third space or endoscopic surgery, you need to learn more about the electrosurgical generator. The electrosurgical generator that we currently have access to is extremely powerful and has numerous settings. I think that in order to do these procedures safely and effectively, uh, the devices and the procedures don't. The devices and the generator doesn't need to improve. I think the physicians need to improve. They need to improve their understanding on how to adjust settings. And just get comfortable, with the generator. It's intimidating, but as you use it and as you learn, in a sequential fashion, it really unlocks a lot of neat things that you can do, especially when it comes to hemostasis and how to address different types of vessels. The most important thing with third space procedure is it's better to treat vessels. It's better to prevent bleeding than to treat active bleeding. And so a lot of the energy settings are useful in terms of prevention of bleeding, depending on the types of vessels. So I'll use all kinds of different coagulation settings from, a low force coag like at 10 watts. I even use low spray coag at 10 watts, which a lot of people aren't familiar with. And then underwater settings, if you go, a lot of people are going more and more underwater, but if you're underwater, the settings or under saline, the settings are even more different. And so you have to understand how energy gets dispersed and how to adjust your settings to coagulate vessels underwater. But the generator can do all these things. The devices, the knives that we use, are all have different hemostasis capabilities. But it's really up to the physician or the endoscopist to know how to use these settings and adjust these settings.
And besides your talk, which I thought was absolutely great, what other resources do you think? What are the useful ones you think people can lean towards to learn more? Because it can be a little intimidating to start
Yeah,
with.
all the reps are all pretty good. So I encourage, especially as you're kind of experimenting with things, have the electrosurgical generator reps tend to be very well educated, and so I would bring them in. You know, we do some proctoring as you're learning third space. I would definitely take advantage of proctoring opportunities. And it's not, again, when I proctor people, I spend a lot of time on generator settings and how, basically, people in the labs, that we've taught people how to do the knives. The part that's missing in a lot of the labs is, how to adjust the generator and, how to deal with hemostasis and prevention of bleeding. So a lot of the proctoring is really focused on those techniques. Um, but just get as much experience as possible and don't be afraid. Like watch a lot of cases, watch a lot of videos. There's a lot of resources online. I know I've given a lot of lectures and they've been recorded, so they're somewhere. And so, uh, but
For sure.
I feel that that's the most important part of my practice is knowing how to use the generator.
What do you think about microwave technology for hemostasis?
Um, it it's interesting. I've used it a little bit. It's different. So you have to understand that with microwave, that it's an antenna, right? It's not like our monopolar devices. So you don't need. The nice thing is you don't have to put a return electrode or a grounding pad on the patient. The challenge is you have to understand each microwave device is going to be different. And there's something called a field. It's like your microwave, right? There's a field, and what it does is it oscillates a certain molecule, right? There's a frequency, and this is getting to physics, but hopefully everyone remembers this, right? So there's a frequency that is put out by this microwave, and it oscillates certain things, and certain molecules have a resonant frequency. And so the frequency, like the speedboat, it's one of the resonant frequencies is on water and blood, basically, right? So it will heat up a vessel preferentially and get that nice and hot and coagulate that vessel. But it can also coagulate and heat other things if you're not careful. And so the nice thing about knives and monopolar knives and coagulation graspers is exactly, current is only going where you touch it. Whereas with microwave, you have to know where the field is, because current, basically you are heating anything that's in that field that that resonates with that particular frequency. So I'm not. I don't know what the future of microwave-based hemostasis is. I do think microwave, will be used in the field of endoscopy. I think that it's more ideal for ablation of tissue with a specific field. So I think we'll be using it more for tumors and maybe biliary tract applications. I'm still
To be determined.
yeah,
To
to
be
be determined
determined.
when it comes to like resection and hemostasis during resection. Because I mean, the problem is the last thing we need is yet another generator. And surgeons have pretty much been doing all their operations with the same generator we used. And so, one of the arguments is, oh, we need to get away from monopolar, or we want to go to bipolar, and it's better for the patient. There's really not that much data that says that monopolar is actually bad for the patient.
Yeah, switching a little bit away from the ESU, you mentioned about stricturing and steroid injection. So two-part question. One is what kind of steroid? And there is some data looking at PRP at the time of EMR. And do you think PRP stem cell maybe for delayed bleeding? And I don't know that it helps at the time of resection. So two-part question.
That's a good question. I mean, PRP, I've recently got like this tennis elbow from doing too much endoscopy, and they've talked about doing PRP into that too. So I think PRP can be used for virtually anything to help, heal. And so it's intriguing, and it's certainly worth investigating. I think, again, we need a little bit more data on that.
It's amazing now they're doing to joints and into every space, and we use it for our hiatal hernia repairs. And so there's like a little bit of data for EMR, but I don't know of your experience for ESD.
I haven't used it. I think that it probably does something, whether or not it's, something, significant enough that we need to be doing it, but, certainly unlikely to cause any harm. So it's an intriguing space. Yeah, I'm glad you brought that up. In terms of steroids, I usually just use, triamcinolone, just like when we're, treating strictures after we dilate. But what I do is I actually use a spray catheter, and to make sure I don't inject it into the muscle. And that I push the spray catheter into the submucosa. Part of this is, in order for this to work, there has to be submucosal left, right? And so if you dissect too deeply and don't leave any submucosa, I think that increases your risk of stricture formation. And so there's this, the Japanese who are really good at this and are very meticulous and have the lowest rate of stricture formation that I'm aware of. I think they do that because they don't get muscle injury. and then you're able to inject steroid into the submucosa. Whereas if you get muscle injury, by definition, there's no more submucosa there, right? And so you can't inject steroid into that location. So, I think that the ability to inject steroid into submucosa means that you still have submucosa left. And some people have been using systemic steroids too when they really want to try. But the reality of it is, you talk with, I think it's underreported, but the incident, the frequency of recalcitrant strictures is extremely high with circumferential resection, especially in the US, because these are often very fibrotic. So it's really hard to avoid any muscle injury even. So no matter what we do, and no matter how hard or how careful we are with the resection, I think in many cases, it's really unavoidable.
You also mentioned the use of cutting current versus coag. Have you embarked on that strategy?
I do that. So the way I do ESD in general is I have this saying, I cut to cut and coag to coag. So I actually don't use like any coag. I don't use like force coag or spray coag or swift coag or precise set. I don't use any of those settings for my dissection, even when I'm doing ESD. So I will cut with like an endocut eye current if I use the Irby. And then if I see a vessel, so I'm very careful. I'm not like, Speedy Gonzalez. I'm very meticulous with the dissection. And then if I see a vessel, I'll pre-coagulate it with like a low forced or a low spray, and then I'll cut through that. Or if it's a big enough vessel, I'll take coag graspers and coagulate it. And I do almost all of my dissection with cut current.
In your experience, which traction methods have been most effective when you're dealing with fibrotic or recurrent lesions?
It depends on the location, but any form of traction. So it really depends on where you are and whether the ideal tractions are ones that are not tethered to the scope and they don't have something coming out of the patient's mouth, right, or rectum. So my preference really is to use like the rubber band method. So what is it? SureTrack by Microtech is the one that's on label. I like that one a lot. And it's relatively inexpensive. So if you need to use more than one, you can do that. In the stomach, it's much harder to use a SureTrack because the lumen is so large. And so I actually like to use the traction wire there because that can be placed on the same wall just behind the lesion and it retracts it nicely. If I have to, then I'll use a clip, and I like the simplest clip method. So either just a clip and line or a clip line pulley method where you have a clip with a line, you put that on the lesion, and then if you want to retract away from you use another clip and put it on the opposite wall and use like a pulley system. So those are the kind of the methods that I use, but it depends on where you are and the geometry you're looking for.
Talking about things that are possibly underreported, I wanted to ask your thoughts on the technique for that we all should be using quite a bit and maybe is not as widely used as thermal ablation of margins for the for the piecemeal EMR. And that is a segue to my next case, but I wanted to ask you that. So what are your thoughts?
So thank you so much for bringing that up. That's actually another thing that I really do want, I think needs to be talked about because I don't, there have been some very nice randomized control studies, both by, Michael Bork and then, with
Others.
Doug Rex and others that have shown that margin ablation clearly decreases the risk of or the likelihood of recurrence. And so I think that this is a real problem. I think recurrence post EMR, piecemeal EMR, is such a big problem. That's why I prefer to do ESD or at least hybrid ESD, because I think that is the best way to make sure that you have a clean margin, is to take it out on block and use a knife to clearly cut around the margins, and the pathologist can tell you if you got everything or not. Whereas if you do piecemeal EMR, the pathologist can't tell you anything except for what what type of histology it is. But having said that, piecemeal EMR is around for a little while to stay until everybody gets comfortable with doing ESD and on-block resections, which probably isn't going to happen during my career. So, having said that, I do think margin ablation is important, but I think one thing that hasn't been stressed enough is how to do margin ablation. And they just say, oh, you use snare tip soft coagulation, 80 watts, effect 4, I think. 5, yeah. So that's dangerous. I think, this is where you really need to understand energy. And it's not that easy. And I've actually heard of several cases of delayed perforation after doing that. And I'll tell you why I think that happens. It's because soft coagulation, like I mentioned somewhere else, is soft coagulation is deep coagulation. Soft coagulation is the worst misnomer of any generators that are going. I know another company calls theirs gentle coagulation, which is even worse, right? I mean, it should be called deep coagulation. It's the deepest coagulation of all the coagulations. And, the best way to explain it is it has kind of what we call the lowest frequency profile. And if you put it in terms of music, that's bass, right? Bass is the lowest frequency. It's the most penetrating. It goes deep. And that's what soft coagulation is. It seems safe. It won't cut. Okay. So on the surface, after you do it, you will never have an immediate perforation related to using soft coagulation. But instead, what you'll have is the worst complication you can have in endoscopy, and that's a delayed perforation, right? And it really happens because, one, doing margin ablation with snare tip soft coagulation is actually can be technically challenging, especially if you want to do a really good job at it. And then there's another camp that really believes in also ablating the base, right? If you ablate the base with soft coagulation and you don't close that defect well, you will get a delayed perforation. I guarantee you. Okay, because that you have then by ablating the base, you have a transmural muscle injury. Right? Is just not an immediate perforation, but you've basically devitalized that muscle with soft coagulation. So, everybody needs, if they're going to do it, everybody needs to know how to. I'm not saying not to do it. I'm saying you got to know how to do it, and you have to understand the energy. You have to understand what you're trying to achieve. You have to understand, how to manage the snare tip. The other option is APC. And everybody thought, oh, like ABC, it seems so violent. APC is actually very, very superficial. Right, you can safely APC directly to the base of a lesion, assuming you don't use forced APC, at a high power, but you use something like a precise APC. You can safely ablate the base. You can safely ablate the margin. So I would say, those who maybe might not have the technique or are in a difficult location and it's hard to maneuver, really consider using APC, especially if they feel like, they didn't get a really clean margin. But, understand the energy, bottom line, understand the energy, understand how to do it. It's your responsibility. And you can't just say, well, it was reported, in a couple studies and that's why I'm doing it. There is technique to this. And it's not super straightforward. So just be cautious, know how to do it well.
So since we're talking about the recurrence, that's the case. And this is the patient who actually had a 4-centimeter rectal polyp around the first valve of Houston, and that was removed piecemeal at outside facility. About 9 months prior, the patient came to us. And the pathology was reported moderately differentiated invasive adenocarcinoma arising in tubulovenous adenoma. And it was unclear in that reports because we couldn't actually get the actual report. It was kind of typed in a note of somebody. it was unclear whether there was tubular villus adenoma that was involving deep resection margin or it was a cancer. And we knew that there was no evidence of vascular invasion. And that is actually just the images of extensive tattooing, which I wasn't quite sure why tattoo was done in the rectum
Yeah.
on the 4 centimeter lesion. And we had an extensive discussion about what to do about it because recurrence appeared to be relatively small. And we actually chose to do FTRD for that. And pathology was a residual adenomatous change, was a low with a small, really small focus, and it was negative margin, and muscular propria was present for that. Now you can tell me how. One concern I had that it was relatively low, and I was concerned whether the patient would feel. She actually did fine, but whether the patient would feel the clip or not.
Yeah.
So should have we been done anything different or
No, I mean, go back to that. So that pathology result. So go back to the original pathology result. So
which is the hearsay kind
yeah,
of
right. So hearsay. So the deep resection margin was almost certainly the malignancy because it's
really?
pretty odd for an adenoma to be present at a deep resection. Lateral resection for sure, but if it's deep, it likely meant that there was actually
Cancer.
cancer and with submucosal invasion. So, but having said that, especially given your findings, it just means that there was cautery there, right? And so it could still mean that they got everything, but it's just not a negative margin, right? That they're cautery at the margin. So I think the fact that you did, so the first thing is this patient should be presented at a tumor board, right? And everybody needs to be in agreement that,
Yes.
the next step would be to do a full thickness resection, which I
Right.
think is very, very reasonable, especially with all the unknowns. So let's get more data, and this could be potentially curative, but certainly sufficient for staging information. And that's how I'd counsel the patient. I would just say, we're the real reason to do this is for staging, and if we're lucky, we're going to cure you because there's not going to be any residual disease. And so, what I suspect happened was the first time that they did the piecemeal EMR, they got everything because they got everything. They got all the cancer. They got all the cancer because, there's no residual cancer here. And then you removed all the rest of the adenomatous tissue. The initial pathology is important in that there's no LVI. I think there's more and more data coming out that the depth of invasion is less important, and the most important predictor for risk of lymph node metastasis is LVI. And so if there's no LVI and the grade of the pathology is, moderate to, well to moderately differentiated, I think you have a low risk lesion. Especially in that location, the surgical answer would be an APR, which would, be life changing. And so I think this is absolutely appropriate. Also, appropriate would be as if the surgeons wanted to do, a transanal resection. But I think that this is easier, and our surgeons would have requested us to do exactly the same.
Would you do in the US prior to this second?
I wouldn't do in the US. I don't think there was nothing on the path that suggested if there was LVI, I would absolutely do it. And in fact, what's interesting is that it seems like the colorectal oncology world is moving away from rectal EUS. Right? There's more and more MRI. They like MRI, and then now you can get MRI PET, and you can get all these other kind of enhanced images. And so we're asked to do staging much, much less. In this case, I wouldn't have done it because I don't think it would have changed anything. If you're going full thickness, if I were to do an ESD, I might think about it. But even then, I kind of look at it and, I base more these days. I do less EUS for kind of mucosal type lesions and do more careful endoscopic evaluations, looking at pit patterns and, trying to do genetic classification or whatnot to determine if there's any invasive component.
But you just was part of the study that showed that fail ESD is really a choice for failed EMR procedure and does perform really well.
Yeah.
I think recently came out. If you want to mention just a little bit about that. While I moved to the study.
So about
that ESD is performing quite well for the failed EMR.
Yeah.
So that could have been, it could have been an option, right?
I still would have done an FTRD. I base it on size. I base it on size. And so, that is a perfect size for the FTRD. Now, I guess the one caveat would be, and this is where I would be cautious, if it is anteriorly located in a woman, you have to be a little bit more careful because there are structures that can be, especially if they had prior hysterectomy or prior pelvic surgery, there can be more adhesions. And so, you could have kind of critical structures that you don't want to inadvertently do a full thickness resection on. And that might be the one reason I would think about doing an EUS is if it were anterior, I just want to make sure that there wasn't anything adjacent to the bowel wall that I might bring in, or I would do an ESD in that case where I'm guaranteed not to, go full thickness.
Well,
that's a real nuance. I got to be really thinking to do that.
Well, we talked a lot about the colon, and I want to just for a few minutes we have left pick up your brain on the upper parts in the stomach. And this is a case of a 61-year-old Korean lady who previously had a plastic anemia and had a bone marrow transplant, and now has been diagnosed with MGAS and had an incidental finding of an antral lesion and picked up on a PET scan. And patient is absolutely fine from GI standpoint, which was PET avid. And this is the lesion.
How avid was it, Sonia? Sorry.
It was at least 2.5, 3 centimeters.
Yeah. So what's interesting is gastric cancer usually isn't PET avid. So, our gastric cancer surgeons, routinely don't ask for, PET CTs. This is an interesting lesion. So it goes across the pylorus into the duodenum.
It's kind of prolapses into the duodenum.
Okay.
And then I think I have a NBI view of it is coming up.
Okay.
And
interesting. I mean, it has hyperplastic features.
Well, I knew you would get that, but it's like, yes. And since we said no EUS, I think there is a little bit of EUS there, which just shows that. And the biopsy of that was a hypoplastic polyp. And there was negative for intestinal metaplasia, although we just had the case. We haven't done any mapping or anything like that. So you actually was a senior author and a recent AGA clinical practice update about sort of surveillance of individual for increased risk for gastric cancer. Well, she would be the one, right? And now is the hypoplastic polyp. So what can we be doing better? What are we and I know the guidelines go extensively. If you could summarize maybe the important points.
Yeah. So a couple of things. One, just related to that lesion, even though it's just hyperplastic, it's over 3 centimeters. And so as they get larger, they do harbor potential for malignancy. So it should come out. And probably has to come out by ESD. And the thing that I don't like about these lesions is they, for some reason, sometimes they come back. They're often these hyperplastic lesions, or it doesn't matter how wide a margin you take. I had one. I took it. It's like I got everything, and back on my surveillance, it came back. So, but it's good to definitely resect at least once, and hope it doesn't come back, and evaluate for pathology, because they can undergo malignant transformation. So that's very important. In terms of her other risk factors, so did she immigrate to the US? She's from Korea?
Yes.
Yeah. And so, important things for her. One, so what the recommendations would say for someone like her, she's considered high risk because she's an immigrant from a high risk or high incidence country. And Korea in particular, both Korea and Japan both have screening recommendations, screening and surveillance recommendations. So she is someone who should have started getting biannual endoscopy at the age of 40 if she were living in Korea. And a lot of people say, well, she lives in the US, so things have changed. For first generation immigrants, they basically have the same risk as those of native Koreans or native Japanese. And so that's one thing. Number two, the recommendations are, and this is both from the AGA-CPU and the recent ACG guidelines, is that in someone who is considered to be at high risk, one, you want to do a really careful examination. You can often see signs of chronic atrophic gastritis and intestinal metaplasia on good NBI imaging. And so if you do good NBI imaging, you'll see kind of the splotchy, patchy appearance, or it'll enhance the atrophic gastritis. In those patients, you definitely need to do mapping biopsies. And when you do the mapping biopsies, you need to separate the antrum from the body. And we typically just recommend at least a Sydney protocol. So the Sydney protocol is 2 antral biopsies, one antrum lesser curvature, one antrum greater curvature, and then an incisura biopsy. Those 3 go in one model. And then you do body lesser curvature, mid-body lesser curvature, mid-body greater curvature. Those go in another bottle. And then you want to ask the pathologist to report on H. pylori. So oftentimes they need to do a special stain to see if there's H. pylori. And then 2, to look for intestinal metaplasia. And really, we had a great session at DDW where we had a pathologist there, Greg Lowers, who is involved in intestinal metaplasia and gastric cancer, and he also feels strongly that pathologists don't do a good enough job in the United States on grading the severity of intestinal metaplasia. And it's actually it's something that's not that difficult to do. Also, the reporting of incomplete type intestinal metaplasia. And the reason that that's important is that there's something called Olgum staging. And Olgum staging basically is severity of intestinal metaplasia in the antrum and body. You can determine a stage that has been shown in several studies now to really correlate with the risk of gastric cancer developing in these patients with intestinal metaplasia. So that's where the field is going to. So eventually we have to, and I'm fortunate enough here at Stanford that our pathologists are fully on board. So for the past, I think, 5 years, we've been able to do full Olgum staging. They tell us if there's incomplete type. They give us the severity. And I think that's where the U.S. pathologists need to go. That's a verbose way of answering your question. So.
Yes. Well, we can for sure sit here for many more hours and ask you many more questions, but I'm sure you would want to go home at the end of a long day. So I want to thank you. It was a wonderful discussion, and we always learn a lot. And thank you, Dr. Krinsky and Dr. Nguyen, for
Thank you so much, Juha.